This is video 2 of our cardiac lecture. We left off on this slide talking about arterial sclerosis and atherosclerosis, risk factors, hypertension, diabetes, uh, obesity. Those can all be risk factors for cardiovascular issues. Once someone has these issues, again, we have to figure out what's causing them. And when you talk about risk factors, you have to think about what's modifiable and what's non-modifiable. And this is a big part of nursing education. So modifiable risk factors would be, can you lose weight? Yes. Can you control your diabetes? You can certainly try. Can you control your hypertension? Yes. Can you control whether you have a high salt diet or a high fat diet? Yes, all of those things can be controlled. Those are modifiable risk factors. Non-modifiable risk factors are things like genetics, sex, age. Those can't be modified. And when you look at risk factors, modifiable risk factors are hypertension, obesity, diabetes that's uncontrolled. Non-modifiable, if you're dark-skinned or African American, if you are over 50 years old, and then the older you get, the worse it is. Women, both men and women have arteriosclerosis, atherosclerosis. Women die from these things more than men do. Those are all risk factors that you need to consider, and when you're educating the patient, you certainly need to address them, especially women who tend to ignore their signs of illness. First sign when there's a cardiac issue, the first thing we're going to go into is acute coronary syndrome. And acute coronary syndrome just means the heart is not happy. So the first thing that someone's going to have is probably angina, or angina, whichever way you want to say it. If you want to stop this video now, there is a video on acute coronary syndrome, and it goes through the different kinds of angina, what they do, and risk factors, that kind of thing. Now I'm going to assume that you've watched this, and I just want to narrow things down real quick. There are 3 kinds of angina. Stable angina, which is chest pain that as soon as you relax, it goes away. This is kind of the most common. And just imagine running. Anybody that runs and then their legs start to hurt, when they stop running, the legs stop hurting because they're getting the proper oxygen supply. So stable angina will stop with rest. Now, that doesn't mean we should let it continue. Something needs to be done. It's like a little prelude. Unstable angina is chest pain that doesn't stop with rest. And this probably is the start of an MI. I'm not going to say that because there can be all kinds of weird things, but more than likely there is probably an MI brewing here. Either way, stable or unstable, we've got to fix whatever the issue is, and it might be related to arteriosclerosis or atherosclerosis. The third kind is variant, and this is caused not by any kind of oxygen deprivation. It's caused by a coronary artery spasm. It'll happen during rest more than with activity, and it feels just like angina. Very rare, but does happen. When you're thinking acute coronary syndrome leading to MI, stable angina means the heart's just not getting enough oxygen. So as soon as you rest it, it gets better. Unstable probably means there's some sort of a blockage. And when there's a blockage, it causes myocardial ischemia. And myocardial ischemia means oxygen deprivation to the coronary muscle itself. So if you rest and it goes away, the oxygen's coming back. If you're at rest, it doesn't go away, there's probably a blockage. That blockage then leads to myocardial infarction. If the muscle does not have oxygen, it leads to tissue death. It must have oxygen to survive. So angina can lead to ischemia, which can lead to myocardial infarction. Myocardial infarction causes cardiac enzymes to be released, and troponin is the specific one, and that's saying that there is cardio muscle death. So that is acute coronary syndrome in a nutshell. Now let's talk about myocardial infarction itself. Myocardial damage is classified by what part of the heart is involved and how deep that goes. So obviously, if the left ventricle is affected, especially the back part of the left ventricle, that's a pretty serious kind of myocardial infarction because that is the biggest part of the muscle that feeds the body. There are anterior, septal, lateral. Please don't get really involved in figuring out which vessel affects which. If you love that kind of stuff, go for it. But all you want to know is myocardial infarction is caused by a blockage in or damage to a vessel that feeds the muscle of the heart. And obviously, it's not good. There are two things seen on an EKG when someone's in the middle of a myocardial infarction. One is a non-ST segment elevation, so a non-STEMI. The other one is an ST segment elevation STEMI. There's a Q wave present. And again, you don't need to get into all this really deeply except to know that a STEMI is the worst kind. And any kind of myocardial damage is emergent, but that one is more emergent. So here are pictures, and you can see this is the heart, okay, crossed here. You can see here, this is the left ventricle. So the left anterior descending artery, otherwise known as the widowmaker. If this gets a blockage up here, then none of the ventricles getting fed. And a person can die very, very quickly from that kind of myocardial infarction. The smaller and the further down the damage, like if somebody has a little bit of a blockage here, it's gonna cause them some pain because tissue died, but it's not going to take their life like something in a big vessel would. Again, I probably should have said this 2 slides ago, but there is a video on myocardial infarction. I can't remember if I asked you to stop and watch it, but certainly stop and watch that video. I'm going to go back a slide because there are some specifics that I want you to know about on this slide. And first of all, you want to know how we're going to treat it. And no matter what kind of treatment we do for myocardial damage, the treatment is usually the same. So I wanted to come back to this slide because it really doesn't matter which part of the heart. What matters is the faster we can get into the vessel and fix it, the better off we're going to be. So before they go to the cath lab, we're going to give them medications. And now I want to go to this slide that really helps with this. Someone comes into the ER, or I don't know, they don't have to be in the ER. They could be your nursing home patient. And they all of a sudden have crushing chest pain. Classic symptoms, it radiates down their arm, their shoulder, their neck, their jaw, their back, shortness of breath, dizzy and nausea, and sweating profusely. And I mean like totally sweating. Atypical is seen in women more, and women ignore it. And this is why women die. They don't have chest pain, but they might have like cramping, and they think it's some sort of a GI thing. They might be anxious. They might just not feel well. And they might have this feeling of impending doom. Now, sometimes women will present classy classically, but not very often. So we have to make sure that we educate women on how to know the signs and symptoms. And then when they come in, again, no matter where it is in the heart, we are going to start, we're going to do the same thing. First, we'll start with MONA. MONA is an acronym for morphine, which controls pain and breathing, oxygen, which of course helps what little oxygen's getting there is, if we give them pure oxygen, they'll get more. Nitro vasodilates, so it helps those vessels in the heart that are occluded. It helps them open up a little bit more so more oxygen can get through. And then aspirin. And we give them aspirin because if there's a clot that's causing this MI, we want anticoagulation on board. So you want to remember MONA. No matter what it is and whether it's typical, atypical, classic. And then, of course, we're going to run lab tests. Now, we can give all these, we can do MONA before we start any labs. But we're looking for positive troponin, positive EKG. Here, MONA goes again. And then there's the FAB4. And this is what's usually prescribed after we've remedied them. So after we've taken care of it, they've been to the cath lab, then we can prescribe the FAB4, which is an aspirin every day, a statin to reduce cholesterol, an ACE inhibitor, and that helps the cardiac muscle contract more efficiently. And then a beta blocker, which makes the vascular bed more supple, there's less resistance, and the heart can work better. Then, of course, we're going to fix the problem with the cardiac cath or bypass surgery, depending on how severe the problem is. We're going to talk about these more in the next PowerPoint. But know this, and again, these will be more in the next PowerPoint, but myocardial infarctions can cause dysrhythmias, as can the treatment for them, heart failure, cardiogenic shock, and valvular insufficiency if the heart has to work more. And we're going to talk more about those disease processes in the next PowerPoint. And the final slide, when you're studying, remember your job is what is the nurse's job. So use nursing diagnoses to help you. Pain, anxiety, decreased cardiac output, deficient knowledge, activity intolerance. Use the nursing process. And we will cover this more in class. When we review in class, we're going to put all of these things into the nursing process since we've already done the PowerPoints and really try to apply what we've learned. So thank you. This is video number 2 for cardiac. And I will be posting probably 3, 4, and 5. It will probably take for the next PowerPoint. Thanks a lot.